in the program, and it's now my pleasure to announce the chief of this meeting, yes, that is Ivo Petrov, and he will talk about renal denervation. The other talk, which you find in the program, was already given. So we go on now with renal denervation.
Thank you, Professor Matthias. Thank you, Stefan, about giving so interesting and new data. You have spoken already about the future. I will speak about the present. So you know everybody, of course, about renal denervation. Let's take a look at some data. This picture is showing three gentlemen, three of them at the end of the Second World War. In fact, the three of them died by complication of hypertension. The arterial hypertension is one of the biggest killer nowadays, still, unfortunately. And you see there one of them died from brain hemorrhage due to hypertension, and the other with complications also caused by the hypertension. The timeline of history of treatment of hypertension was very curious. In fact, 90% of the medications that are listed here are not anymore on the market, so they're abandoned. And because of many reasons, not efficient, too much collateral and poisonous effects and so on. And the renal denervation is coming in fact on an empty space. This is the space of not efficient medication. So the so-called polypill evidently didn't work for the arterial hypertension. And this is the real data, very nice Italian trial showing that despite of treated or non-treated, 50% of the hypertensive subjects all over the world are not controlled. This is the most important because in the beginning this is combining the non-medicated, the resistant to medication, and put together even more than 50% of the patients are not controlled. And this is definitely a huge gap in the treatment, and the renal denervation came as an idea long time ago. You see, Goldblatt was the pioneer, showing that removing the kidneys, the hypertension is treated efficiently, and also the complete denervation, if possible, of both kidneys, like written here. Complete denervation. This is more than 1 century ago. The idea of making complete denervation of the tissue surrounding the kidneys will have an effect. And in fact, after that, during the 30s of the last century, there were the so-called sympathectomy. Surgical, unfortunately. And during the sympathectomy, the result of the sympathectomy was really dramatic. You see the graphics. You see, this is subjects with arterial hypertension reaching for systole up to more than 200. And after sympathectomy surgical, there is a huge drop immediate. You see 280 to 110. So it's a huge drop both of systolic and diastolic arterial pressure, but with a very high price. The high price was the complication rate of surgery. And because of that, even mortality, some of the patients unfortunately died during this efficient surgery. And it was a very interesting, one of my teachers, Juan Carlos Parodi, who was one of my instructors during my specialization in Favaloro Foundation in Buenos Aires. He did a very nice experiment. He is one of the most experienced vascular surgeons all over the world. You know, he is the father of the bifurcational endovascular treatment of the aorta. What he did openly. So during AAA surgery, he divided the group of his patients in two. One of the group without removing the nerves around the renal arteries, and the other group cutting the nerves around the renal arteries, so renal denervation. And he he showed between the groups a very big difference. So the group that was surgically denervated had much better control of the hypertension, and the majority of these patients are hypertensive. One of the biggest trigger for abdominal aneurysm is the hypertension. So we are jumping nowadays to several different options for denervation with, of course, radio frequency energy, with ultrasound, with the alcohol and so on. But the most data are with radio frequency. The spiral catheter is the most advanced catheter from Medtronic with 4 points, unlike the first generation that was only one point on the tip of the catheter, and this is a huge advancement. What we have learned by the negative, it's not negative, it's neutral trial, hypertension 3 trial, have shown, in fact, in the sham group, also some improvement of the hypertension, and of course with renal denervation, this is the first generation methodology, and with the first generation Medtronic catheter Flex, there was higher effect by the renal denervation, but didn't reach statistical significance, and we have learned why. First of all, the majority of the physicians that were performing the procedure had up to 5 procedures before doing the renal denervation itself, and the majority of the patients, 60% of the patients that was treated, they were not in the sham group, were in the treatment group, received between 1 and 2 points. So obviously they didn't receive renal denervation, and later it resulted that the more points are touched, denervated, the bigger the effect is. So definitely this is one of the reasons. Here is, we are showing, in fact, the number of points, how much important is. And the other determinant was the position of the terminations of the nerves, and it resulted that the density of these renal nerve points are more dense distally and not proximally, and inside the branches and not the main vessel. The so-called Y pattern resulted is the reasonable one. So to treat circumferentially many points, and also included the branches and not only the main vessel. So not only the main vessel, but also to include the branches. We have performed, in fact, very soon after the hypertension 3 trial, we published our data, our proper data. You see in 2018, 2 years after the hypertension 3 trial, we compared the Y pattern to the classic one at that moment, so treating only the main vessel, and with emphasis on the ostium of the renal artery, and it was resulted that treating the main and the branches with more points, it resulted that is more efficient. These are our data that were published in the Journal of Cardiovascular Revascularization Medicine. And nowadays, as shown here in the picture, you see the 4 points of the spiral catheter are inside the branch. So nowadays, we are performing more than 20 points per side. So 20 points at the right side and 20 points left side in the main vessel and also in the branches. Many trials, Japanese trial, Asian trial, sham control 7 sham control trials after the hypertension 3 trial have shown that in fact off-med, on-med, pilot study and so on. So with the new generation, with the 4 denervation points of the spiral catheter, definitely there is a statistical difference both for the systolic and the diastolic blood pressure with better control. And this picture is very important. In fact, the effect of renal denervation is all day long. It doesn't matter if you take the medication and doesn't take, because it's always medication on. It's definitely, this is very important for the so-called non-dippers. So the patients that during the night, in fact, even some of them have higher arterial pressure compared to the daily time. and it's sustained. This is very important. Stefan was taught us many times how obvious there is no regrowth. After radiofrequency electric ablation, there is no regrowth of the nerves. So they are totally degenerated. And because of that, during the time, instead of decreasing the effect, in fact, the effect of the sympathetic renal denervation during the time is increasing. And this is very important, that the fact that there is no price regarding complication. Unlike the surgery, like I have shown in the beginning, the price that these patients were paying was very high. With the renal denervation, and especially with our procedure doing from the arm, I know it's off-label, I know what the people from Medtronic will tell me, but going from the arm to the renal artery is a piece of cake. It's a simple procedure, predictable. It's not possible to have complication. There is no, not only reason, there is no mechanism to have complication. Because the new catheter, the spiral catheter, is on wire. Unlike the first generation, with the catheter was not on wire. Nowadays, with the Judkins right catheter, that is so, it's a piece of cake to enter into the renal artery and to go through on the wire by the spiral catheter and to denervate. This is very important that because of all these 7 trials and several meta-analyses and the results that these meta-analyses have shown, both the American and the European guideline changed. And nowadays we have class 2B indication for renal denervation, especially for patients that are uncontrolled. I will finish with very important data, and I will show you 2 cases now. One case that is quite typical. You see usual office values up to 190 to 110 millimeters of mercury. And how many medications? Can you count them? I did count them. 7. 7 medications dedicated for the arterial hypertension. Do you think this patient is willing to take medication? No, the majority don't want to take medication. And the other point is very important, that independently, if the patient is taking the medication and is not well controlled, or other patients, they don't take the medication and are not well controlled, the result, the clinical result is the same. So independently, if the patient is resistant to hypertension medication or not, in case the hypertension is not controlled, it's equally bad clinical result. So the both groups, they are indicated, and this is the biggest conclusion from these trials. It's very important to emphasize. This slide is very important. In fact, the patients that are resistant to hypertension medication, they have the highest possible atherosclerotic risk. And because of that, when we have in the office a patient taking too many medication for arterial hypertension, you have to know this patient has a very big atherosclerotic risk. And the patient selection is clear. It's very important to take a look at the renal arteries, definitely, to see all the renal arteries. I emphasize all renal arteries, not only the main renal arteries, but also accessory renal arteries above 4 millimeters of diameter, a target for denervation. Because it's in fact the more points we denervate, the bigger result we have. And of course, in case there is a clinical indication, we have to take a look at the renal arteries by the Doppler. And in case the renal arteries are in a good shape and good diameter, these patients have to be treated. And this is this patient that I mentioned already. You see, this is the ambulatory measurement of this pressure. You probably saw that his pressure was reaching 210 millimeters of mercury on 7 medications. This is our procedural protocol. So we are using the right Judkins catheter coming from the arm for not very tall people from the radial artery, for people that are too tall to have length the catheter. I have taught 6 years ago Medtronic to make a radial-friendly catheter, a radial artery friendly catheter, but I don't know if somebody's listening to me, obviously not. Yeah. And in fact, with a simple right Judkins catheter that we cardiologists can do, I'm joking that we can do everything with the right Judkins. Of course, it's not true, but it's quite close to the truth. And with simple right Judkins catheter, we are entering left and right. We are going in all the possible branches that are more than 4 millimeters to accept the spiral catheter. And we do ablations. And it's a good. And this is in fact how it's done. You see that the catheter is coming from above, not from the femoral. And with this procedure, we are, let's say, paying attention to all branches that are worthy to be touched by the renal denervation points. And you see what is the result. You see here, it's 160, 170. So the patient is not cured, but the peaks, the spikes are removed. In fact, the spikes are very, and this is quite early. And the spikes of the pressure are very, very dangerous. And this is our local national activity increasing because luckily 2 years ago, in fact, the renal denervation entered into the National Health Fund reimbursement list. And this is in fact from class 3, we moved to class 2B. And in fact, probably one of the biggest conclusion is that nowadays, into the guidelines, the renal denervation is indicated not only for patients with resistant to treatment medication, but for all the patients that are not controlled, independently of the mechanism of not controlling the hypertension. So we have, in fact, a much wider, much broadened aspect. These are the guidelines. European Society of Cardiology and hypertension, you see uncontrolled, resistant, intolerant to medication, non-adherent, increased cardiovascular risk, I mentioned already, and also patient preference is already included into the guideline. So this is also quite important to emphasize. And there are many, only we'll mention what else. There are many hopes. The technology is going up. You see there are trials about hepatic artery denervation, but also there are trials. So we are also conducting such a trial, renal denervation in patients after radiofrequency ablation for rhythm disorders, in fact, for atrial fibrillation. And there are data, they are gathering more and more data that in atrial fibrillation post-ablation, the renal denervation is also a very reasonable option because there is a sympathetic tone going down and the probability of recurrent atrial fibrillation is also going down. Thank you very much for your attention.
Thank you very much. Wonderful overview. How and when to use these treatment option. Yes, please come to the microphone. And
okay, Ivo, just 2 questions, because in my opinion, we have a problem with this procedure for 2 reasons. First of all, we still don't have a good interprocedural endpoint to know that we done the job, that we have denervated the arteries. And second, we are still treating atrial hypertension like it is one single disease and it's probably a multi-syndromic condition. So now broadening all this application, I think we may be opening the Pandora case, because 1/3 of the population is hypertensive. If you put a non-adherent in the basket, you can do it. One cath lab can do this all the time. Do you think that you have a future?
You opened two very hot topics. We can speak about more than hours. In fact, this is very important. In order to be a predictable procedure, we need to have good notion, the point where we are. Is it a good point to be denervated or it's useless? This is very important. And there, you know very well that there are some trials trying to measure the impedance, to measure the sympathetic tone, and the point that we are, in fact, to measure even the sympathetic tone of the patient with several neurologic investigation of the sympathetic tone in the muscle. Unfortunately, this, the second one that I mentioned, is too painful in order to have applicability, broad applicability, but definitely you are right. And in fact, even we have to have some notion by clinical point of view of patients that they have really higher sympathetic tone. For example, diabetics, for example, sleep apnea patients. Probably there is a more responder group of patients that there is a higher probability to have a good result, to be responders, and we still need, in fact, this data.
Yes, please.
Perhaps I should have talked about that too, but we are doing another clinical trial called Galileo. And it turns out what we found out is that you can use the same spiral catheter, but don't pass ablative radio frequency, but use a different radio frequency that just tickles the nerves. Same catheter in place. And when you do that in the main artery, the distal vasculature in the kidney basically constricts, very markedly so that you can measure an angiographic response. If we denervate the individual, that constriction disappears. Or you can see one branch constricts, the other branch doesn't constrict, and you can say, I have to go denervate more. So that clinical trial will give you an opportunity in the same box to actually test ablate, and then have some records to tell the general practitioner, the cardiologist, this is what I've done, right? And you have some endpoint. It's not perfect, but it's going to give you some of that. And others are doing different things. So it's coming. The radio also is coming.
Yeah, so medical development is moving all the time. Yes, are there other comments or questions? I have heard that you use also local anesthetics. I will only mention that that should be also used in other selective parts when you do embolization treatment. I always gave a little bit also of local anesthetic into the artery before I occluded it. So there is not that ischemic pain, and the patient will be more relaxed on table.
In fact, I have learned long time ago by an Italian colleague who told us that he is giving through the catheter directly lidocaine, supraselectively lidocaine into the renal artery. And to be fair, by the way, it's not painless. You know, it's not painless. It's not pleasant. And of course, we are giving conscious sedation. But I at least 2 times during the procedure, every side, 2 times I'm giving lidocaine supraselectively into the renal artery, and the effect is impressive.
So that's a recommendation also for other embolization treatments, yes, not only for renal denervation, in organs which are sensitive for ischemia.